Welcome to my 5th psychiatry boot camp, guys. This one is pretty near and dear to my heart. I spent a lot of time on it. I think that it's more fun with the Disney princess cases. I had a lot of fun making it. So I hope you guys have a little bit of fun too. We're going to cover a lot. And it's a, unfortunately, 2-hour long presentation, but don't feel pressured if you can't stay through the whole thing. Like I said, you can put your email in the chat and I will email you a recording, and I will email you a copy of my slides, which I really hope people can share as a resource to, inspire other people to learn more. So our first case that we are starting with is Belle. So Belle is a 28-year-old. She's 8 weeks pregnant with her first child with depression, generalized anxiety disorder, and social phobia. She's taking fluoxetine 60 milligrams daily and Xanax 0.25 milligrams at bedtime. Her backstory. She was severely bullied in childhood, never felt like she fit in. She was struggling with social phobia from a very young age. However, her depression symptoms really kicked in her mid-20s, and she's been on and off various SSRI medications since then. She had a trial of Lexapro, which was effective for her, but she had sexual side effects and weight gain, so she stopped it. And what do you know, 6 months later, her depression returned. So she restarted her Lexapro, but still had the low sex drive and orgasmia. This was particularly difficult for her while trying to conceive. And also when she restarted the Lexapro, as happens to our patients sometimes, it just kind of pooped out on her. It wasn't working as well the second time. This is a risk to patients going off a medication that sometimes it doesn't work again when they restart it, by the way. She was put on fluoxetine while trying to conceive, and it was titrated to 60 milligrams before she achieved full remission of her depressive symptoms. And now she has been in full remission of her depression and anxiety for the past 4 months when she discovers that she is pregnant. And now she's here to see you, her wonderful doctor, about what to do. So Belle tells us, my friend said that pregnancy protects women from mental health issues. She was the happiest of her life during her pregnancy. All the forest creatures were extra nice to her. The birds flew her ice cream. The squirrels did her dishes. How nice. Well, what are the relapse rates of psychiatric illness during pregnancy for women who discontinue their medication? I'll tell you guys, they're not great, okay? 68% have a return in major depressive disorder. And then women with bipolar disorder are particularly vulnerable, okay? We're talking like 80 to 85% of women with a relapse in their symptoms of bipolar disorder if they are off medication during pregnancy. 50% for schizophrenia. So you got a 50-50 shot. So no, pregnancy is not protective against psychiatric illness, which was previously thought. This is a slide I stole from Massachusetts General Hospital, which is an amazing resource on everything women's mental health, okay? Regarding percentage of patients who remain well and those who maintain their medication versus those who discontinued by gestational age. So Belle asks us, well, okay, so what if I get depressed again? Should I just grin and bear it? I heard stress is bad for the baby too. What should I do? So let's talk about that. What is the big deal with a woman being depressed and anxious during pregnancy, aside from the woman, of course, right? There are a lot of negative impacts on the developing fetus as well. Lower maternal weight gain, increased rates of preterm birth, and low birth weight. So our hypothesis is that elevated cortisol, the stress hormone in the mother's system, okay, decreases placental blood flow and also can stimulate labor. In addition, there's another more subtle piece to this, right? And very important, which is that women with depression and anxiety are at much higher risk of engaging in behaviors, smoking, alcohol, and substance abuse than they are when they do not have depression and anxiety, which also have a negative impact on a developing baby. And there are higher rates of gestational diabetes, higher rates of preeclampsia, and just not being excited about an upcoming baby, which increases the risk of postpartum depression. We're finding that children who are exposed to maternal depression in utero have higher cortisol levels, which can continue through adolescence. So this is a long-standing impact, actually, that maternal stress can impact infant temperament, and that treatment of depression during pregnancy can normalize infant cortisol levels. You know, we talk a lot about postpartum depression. Yes, it interferes with appropriate mother-infant bonding, but it's also associated with lower IQ, slower language development, and increased risk of substance abuse and mental health issues later in life in the babies. They actually did a prospective 20-year study of children of depressed parents and found that they were 3 times more likely to develop mental health and substance use disorders. So that is part of why, as a child psychiatrist, I get particularly excited about getting these women on medication early, because it means less adolescence in my office later. So Belle tells us, okay, she's reading the New York Times, the Telegraph. I did my research, and antidepressants are associated with autism and heart defects. What do we say? Well, we tell her about the story of confounding factors, okay? Most studies have not controlled for underlying psychiatric illness as a confounding factor that is a contributor, right? When they compare pregnant women with depression on SSRIs to pregnant women without any psychiatric illness, okay? So it's apples and oranges here. Studies that are more useful compare pregnant women with depression on SSRIs to pregnant women with depression who defer medication treatment, and they have not found an increased risk. So it's suggesting that the psychiatric illness itself is a risk factor, not the medication for the illness. In fact, one study of pregnant women with depression who declined treatment with SSRIs during pregnancy, this is women who declined the medication, found an increased risk of heart defects in untreated women with depression. And studies about autism, it does seem like that increased risk that they found is due to the underlying illness, that is depression, for example, not the medication to treat the illness. So confounding factors are important here. So it seems like when women are pregnant, everyone has an opinion and everyone suddenly becomes an expert, right? I don't know about you guys, but pharmacists are always telling my patients stuff. So my pharmacist, Mrs. Pott, said sertraline is safest. Should I switch to sertraline from Prozac? No, please. So let's explain how that usually goes. Okay. So let's say, you know, Belle, she has achieved a 4-month period of remission of depression. Good for her. So we start the sertraline at 25 milligrams. We increase the sertraline to 50. We decrease her fluoxetine to 40. Then we decrease it to 20, and her depression comes back. Okay. She's depressed. She's anxious. she's on 20 of fluoxetine and 50 of sertraline. And now her baby, let's say it's 24 weeks gestation at this point, has had exposure to sertraline, fluoxetine, and maternal depression and anxiety. If you want to make changes, do it before a woman gets pregnant. The best antidepressant for mommy while she's pregnant is generally whatever the best antidepressant was for mommy when she was not pregnant. Now the nurse is chiming in. My nurse friend said antidepressants can affect how my baby is breathing after birth. So let's talk about this, persistent pulmonary hypertension of the newborn, okay, also called PPHN. So this is when the pulmonary vasculature, the resistance in that fails to decrease at birth to allow proper oxygenation. And it's serious. It has a 10 to 20% mortality rate, okay? An FDA alert based on a 2006 study, which compared infants diagnosed with persistent pulmonary hypertension to those without persistent pulmonary hypertension and found higher rates of SSRI exposure in infants. However, follow-up studies, which adjusted for confounding factors, did not find this association. So we've talked about confounding factors. Okay. It's also important to think about absolute risk versus relative risk. Okay. So the New York Times is going to report on the relative risk usually, right? They're going to be like, okay, SSRIs make babies 6 times more likely to have the persistent pulmonary hypertension of the newborn. But if you look at the absolute risk, okay, that's persistent pulmonary hypertension of the newborn affects 1 to 2 infants in 1,000. Okay, so we're like, even if we forget that this result disappears when we are taking confounding factors into consideration, then that's going to be increased to like 0.6 to like, that's going to increase to like 6 to 12 infants per 1,000. Okay. So still, like 99% of women who take SSRIs during pregnancy are having healthy babies. Okay. Because the absolute risk is so low, 1 to 2 infants in 1,000, even if you're increasing that by a factor of 6, that would be 0.6 to 1.2% of infants, you're getting 99% of women taking SSRIs with normal, healthy babies. So that's something to consider. Confounding factors that affected this study is that women with depression have much higher rates of smoking, diabetes, and obesity, unfortunately. Okay. And they are likely to contribute to things like persistent pulmonary hypertension of the newborn. Now, there's something else, poor neonatal adaptation syndrome. This is like a temporarily really fussy baby. This is confusing to us. Okay, so originally they thought that these babies were really fussy because they were suddenly withdrawing from the mommy's SSRI, let's say it was Effexor or SNRI, and that's why they were really fussy. It does seem more complicated though. There are actually higher levels of serotonin metabolites in the blood levels of infants exposed to SSRIs who have this fussy baby syndrome compared to infants who were exposed to SSRIs who don't have the fussy baby syndrome. So we're not sure, that doesn't quite fit. And also we're finding the fussy baby syndrome is happening in infants born to women who never took any SSRIs. They just had untreated depression and anxiety. But the point is, this is mild, self-limited, usually goes away within a few days. Jitteriness, restlessness, irritability. Now, Belle asks, she's smart, okay? So she asks good questions like, well, can pregnancy affect how well my meds work? It's good you asked that, Belle, because yes, it can. Okay. So obviously, 50% increase in plasma volume during pregnancy, right? So your medication is diluted. There's an increase in body fat. Okay. There's a larger volume of distribution for the medicine. That's one reason that often women need their antidepressant dosage increased during pregnancy. Also, a lot of times the medication is being metabolized faster. Renal blood flow and glomerular filtration rate increase. Also, estrogen and other hormones can affect liver enzyme activity. Cytochrome 1A2 activity actually decreases. Also, a lot of women may quit smoking while pregnant, hopefully, right? And smoking is a strong inducer of cytochrome 1A2. So if a woman is on a drug metabolized by cytochrome 1A2 and they quit smoking because they're pregnant, that drug level is going to rise dramatically. So that's something to be aware of. Okay. Now, Belle, this is Belle's case though, so we'll try not to overcomplicate it. All right. Well, cytochrome 2D6 and cytochrome 3A4 activity increase under the influence of estrogen hormones. Fluoxetine is metabolized by cytochrome 2D6. So that, coupled with her increase in plasma volume, her increase in glomerular filtration rate, she's probably going to need an increase in the dose of her fluoxetine in the third trimester. I would not be surprised. So these women need to be followed rather closely. And I think she also needs a referral to couples therapy because, well, the beast. Seriously though, Belle and Beast should go to therapy. Okay. There is a direct correlation between how much therapy a parent has had and time spent understanding themselves and making sense of their own childhood and their child's social emotional health. Direct correlation. Bruce Perry has a quote: "We elicit from the world what we project into the world, and what you project is based upon what happened to you as a child." And get ready, parents, when you have a baby, your childhood trauma comes back. It does. It's time for it to get active again. Additionally, we cannot receive, I'm sorry, I said that wrong. We cannot give what we never received ourselves as parents. Parents might talk about like, well, don't disagree in front of the kids. Actually, it's so much more important how assertive and respectfully parents disagree and then can still be together in front of their kids. And how they disagree is more important than how often they agree, right? That they can model that healthy dynamic. So they went to therapy, and Beast was able to stop using power and control as a surrogate for self-esteem. He gained the emotional regulation skills to manage his anxiety and anger, so he could tolerate the emotional vulnerability he needed to authentically, emotionally connect to his family. I'm telling you, our society does men a serious disservice when it comes to this. So good for you, Beast. My whole presentation really focuses on moms. This is one slide on dads. I realize that. I'm very sorry. But we definitely should not forget them in terms of how much support and treatment they can benefit from, and their children can benefit from them getting. I love Terrence Real's book. I don't want to talk about it, Overcoming the Secret Legacy of Male Depression, by the way, if you want a good read, and it comes as an audiobook. So Belle and Beast Library gets this big upgrade, and they also read some of Terrence Real's other couples books. Actually, I'm reading a new one that isn't even on this slide right now. It's called Fierce Intimacy. It's really good. So these are, I think it's very empowering for patients to have resources like books to start this journey, to have things that they can really do to empower themselves in learning and not just see therapy or psychiatric treatment as something that's done to them, but something that they're doing with us. All right. So Belle wisely, I think, continues her fluoxetine and asks, but what about my Xanax? What about that Xanax, guys? Xanax and pregnancy. Let's do it. All right. Benzodiazepine medications in pregnancy. So there's been more reassuring data. Okay, like earlier studies suggested an association with cleft palate. A recent meta-analysis did not find an increased risk of cleft palate. However, some studies have found that benzodiazepine combined with SSRI medication, not SSRI medication alone, the two in combination had an increased risk of congenital heart defects, though the absolute risk was small. And this is another piece that makes it difficult in helping our patients interpret these studies is that a lot of studies don't control for other medication exposures during the pregnancy. So was the woman taking an SSRI and Xanax or an SSRI and Benadryl, et cetera, right? So a little more reassuring than we thought. She says, there are so many different studies, and my library is a little bit out of date. How do I keep up with all this information? Ariel keeps saying I need to buy a laptop, but then which sources of information can I trust on the internet? All right, guys. You don't have to remember anything in this presentation except this one thing. You don't have to know this information. You just have to be willing to go to the right sources to look it up. And it is very easily available at these sources online. I created this whole presentation using sources that were pretty easy to get. The National Curriculum in Reproductive Psychiatry, Massachusetts General Hospital Center for Women's Mental Health has awesome articles. You can print articles for your patients from the Mother to Baby website, okay? You do not have to be a reproductive psychiatrist to find this information and give it to your patients. Also, I know a lot of people don't have as much access to psychiatrists as they would like. Massachusetts General Hospital runs a reproductive psychiatry consult line. So anyone can, it's scheduled, you have to schedule an appointment. We actually did it in my office. My PA Bethany did it and told me how it went for her. You can, for free, schedule a consultation with a reproductive psychiatrist there. How cool is that? Okay. So Belle's like, I don't like this whole like cardiac defect, possible low risk when combining an SSRI plus Xanax stuff. I don't want to risk it with my Xanax, but I can't sleep without it. So I guess I just have to give up on good sleep for a while. Well, let's talk about insomnia in pregnancy now. Up to 95% of women experience sleep problems during pregnancy. Geez, that's a lot, okay? And there's so many factors that play into that. Insomnia during pregnancy, unfortunately, significantly increases risk of both depression during pregnancy and postpartum depression and anxiety. It also, interestingly, predicts postpartum OCD. So restless leg syndrome, obstructive sleep apnea rates are higher that can produce poor sleep. A small study, 54 women, okay, got treatment for their insomnia during pregnancy with diphenhydramine and trazodone. And some women didn't, and they found that treatment with trazodone and diphenhydramine reduced the severity of their postpartum depression symptoms assessed at 2 weeks and 6 weeks after delivery. So we have some evidence that treatment of the insomnia will decrease the woman's risk of depression and anxiety postpartum. Unfortunately, tricyclic antidepressants, we're talking like amitriptyline, nortriptyline, even though they cause weight gain, they have a lot of side effects, at least they aren't associated with increased risk of congenital malformations. We talked about benzodiazepines and the Z drugs. They are controversial, right, in pregnancy. So we prefer things like diphenhydramine, trazodone, okay? Now she asks us, okay, this is a great question, guys. You ready for this one? Maybe I should use marijuana for sleep, huh? All the villagers say it works great for them. It's natural, so that means it's safe, right? Yeah. Okay, cannabis and pregnancy. This is really on the rise. So much so has this increased in frequency, the use of cannabis in pregnancy, that the American College of Obstetricians and Gynecologists recommends universal screening for cannabis use and counseling versus its risks. I know I'm seeing it a lot in my practice, unfortunately. Data suggests that prenatal cannabis exposure does increase risk of intrauterine growth retardation, low birth weight, small head circumference, increased chance of NICU admission, deficits in memory, attention, and learning in adolescents. Also increased risk of cannabis and nicotine use in the adolescents who were exposed prenatally. So there's a growing body of literature about the negative impact of cannabis on the developing brain, and a lot of women do not understand this risk and really need us. And they're not going to mention it. A woman is not going to come out and tell you, hey, I'm smoking weed, unless you directly ask, because they're afraid. A quote from Ariel. Well, Ursula says she's holistic and uses only natural ingredients. We know how that story turned out. Addressing the naturalistic fallacy. The naturalistic fallacy is a thinking mistake that we believe that a substance is safe if it's natural and unsafe if it's man-made, when in actuality, safety, effectiveness, side effects have nothing to do with whether something is man-made or natural. And so encouraging patients that a truly holistic approach means utilizing all resources, medicine, exercise, psychotherapy, pursuit of meaningful activities to address their mental health, not a reductionistic approach that is anti-medicine. We could do an entire PowerPoint on that, by the way. So what are we doing about Belle's sleep? She decides that she's going to switch to diphenhydramine. And I want to point something out here. Okay, Belle was taking 0.5 milligrams of Xanax. What would we do if the woman was taking like 2 milligrams TID? We would keep it the same, okay? If a woman is on a high dose of a benzo while pregnant, you do not want her to go through tapering and withdrawal while she's pregnant. You really don't, okay? It's safer to just leave it alone if she's on a high dose. But she's on a very low dose. So, maybe decrease 0.5 to 0.25. Then you can get one of those, even tinier, 0.125 and stop it. She switches to diphenhydramine. And because she has bought herself a laptop now, she goes to Massachusetts General Hospital's Women's Mental Health Essential Reads and reads about cognitive behavioral therapy for insomnia. She starts a CBTI program that teaches her sleep hygiene, relaxation training, and how to correct her cognitive distortions regarding sleep. Good for you, and for you using the internet. So that's Belle's case. We're going to do 2 more before we're going to have a little intermission where Dr. Ciprolata is going to speak, okay? So if you guys are ready for Ariel, I'm not ready for Ariel yet. Hold on, I need something. Oh, yeah. All right. I love Ariel. Probably tell she's my princess, guys. Now I'm ready. Ariel. She's a 22-year-old who is 24 weeks pregnant with her first child. She's got ADHD and PTSD from some complex childhood trauma. She is on Concerta, methylphenidate ER, 36 milligrams daily, and Intuniv, guanfacine, extended release, 3 milligrams in the evening. So what do we do? There is no one right answer for everyone. I think that's a theme, honestly, of this PowerPoint when it comes to psychiatric treatment during pregnancy, postpartum, and perimenopause, that there is no one right answer for everyone. We are there to help patients weigh the information and make the best choice. Treating ADHD. So the choice of whether or not to continue ADHD medication during pregnancy depends on the severity of ADHD symptoms. Women may or may not need to continue stimulant medication during pregnancy, right? What happens to them when their ADHD isn't treated? Well, let me tell you, untreated ADHD is associated with increased risk of motor vehicle accidents, loss of employment, substance abuse, financial distress, marital conflict, and risk-taking behaviors. Some women may have employers who may or may not be able to offer more accommodations for them. So in the past, honestly, in the past, we leaned toward don't take any meds during pregnancy. Now we know better, right? We are understanding more about the risk of untreated psychiatric illness during pregnancy. And we're understanding that we're not weighing the risk of a healthy mom, pregnant mom, against a mom taking medicine. We're weighing the risk of mom's untreated psychiatric illness against the risk of the medicine. So there are studies of women who abuse stimulant medication that had higher rates of prematurity, growth retardation, and withdrawal, again, in women who abused stimulant medication. More recent studies have not demonstrated a significant increased risk in malformations. There may be a slight possible increased risk in cardiac malformations, okay? Women who are on stimulants during pregnancy should be carefully monitored, though. There is an increased risk of hypertension and less weight gain due to the appetite suppression of stimulants. So we ask Ariel questions to help her decide what is right for her. Okay, question 1. Ariel, how have you functioned in the past without the use of medication? I couldn't find any of my who's its and what's its. I forgot my dad's concert. Honestly, the hardest part was when I was fighting with Eric all the time because I kept letting him down. All right. Well, what about impulsive, risky behaviors, Ariel? Well, I made a really bad deal with the sea witch. Ooh, and one time I forgot pants. Okay, it's getting worse, guys. How does your ADHD impact your safety driving? Well, so we're taking all that into consideration here. What about switching Ariel to a different medicine, huh? What is the data we got on other ADHD medications in pregnancy? Bupropion has relatively reassuring data, but doesn't have as large a body of safety data as other antidepressants during pregnancy, and it doesn't work as well as stimulant medication. So, okay, bupropion. If a patient is taking bupropion and they're pregnant and it's going well for them, fine, stay on it. But the evidence does not justify switching from a stimulant to bupropion if a patient who is pregnant is doing well on a stimulant. Unfortunately, we have very small studies for atomoxetine and guanfacine and clonidine, okay? Essentially, that means we don't know because the studies are so small. This brings us to another good point in interpreting data. Absence of evidence of any risk is not evidence of its absence. So, and this is why the pregnancy categories are bonkers, right? because a brand new medication, let's say Vraylar and Caplyta that just came out, are going to be like, I'm pregnancy category B, because there's no evidence of risk, because there's no study whatsoever. So we do have large bodies of data on the older medications. Patients may erroneously view medications with these large studies, so there's some evidence of risk, though it's low absolute risk, as scarier than medications where there are very small studies, which show no risk. So then there's no risk, right? No, it's just a very small study. It's not large enough to tell you the kind of risks that are found in larger studies. So helping patients understand confounding factors, helping them understand absolute risk versus relative risk, and helping them understand the amount of people in the study matters. That's a lot, right? What does Ariel decide? She stays on her Concerta, okay? She takes the typical 36 milligram dose for driving, for long castle meetings. She takes a lower dose, 18 milligrams, on like less intense days. Sometimes she skips it. And that's a nice thing about ADHD medicine, right? You could take different doses on different days. We monitor her blood pressure, we monitor her weight, we monitor her intrauterine growth very carefully, and her pulse. She does decide to taper and discontinue her guanfacine because the information on guanfacine is basically, we just don't know much about risk and safety. She also finds that the guanfacine medicine is just less integral to her day-to-day functioning. And because guanfacine lowers blood pressure and worsens orthostatic hypotension, which is already an issue during pregnancy, there is that risk too with guanfacine of worsening the orthostatic hypotension that these women are already at risk of. She decides she's no longer with her guanfacine, right? And she's going to really dig into addressing her PTSD more. She undergoes a combination of EMDR, eye movement desensitization reprocessing therapy, and some psychodynamic oriented psychotherapy, and gets support from her family and employer. She asks us though, I lost my mom at a really young age. How am I going to know how to be a mom to my baby? I've been reading about human babies. They can't just be left alone like a clutch of fish eggs. How do I connect to my baby when no one did that for me? This is a good question, guys. What kind of resources can we give her to help? Well, she reads the Circle of Security book, Raising a Secure Child, and learns how to balance that support and limit setting to be a secure base from which they can run off and explore, and a safe haven for them to return. She also reads a lot from Daniel Siegel and learns about secure attachment, how important it is to make children feel safe, that a parent will protect them from harm and will not be a source of fear. The home is a haven. Make children feel seen. Parents demonstrate that they understand how a child feels and what they are thinking, or at least that they are curious about it and trying to understand what the child is thinking and feeling. They don't shame or judge the child. They're open and empathic. Secure. The parents are reliable and consistently present. They make an effort to repair the relationship when there are disagreements. They connect with the child before they correct the child. And soothed. They attend to their child's emotional needs, they comfort them, they demonstrate and teach good emotional regulation skills. Ariel works really hard with her therapist. She gets a better understanding of how her early childhood experiences impact her effectiveness as a parent. She recognizes that all that hoarding stems from early childhood neglect and scarcity of resources, that she tends towards helicopter parenting because she was left alone as a child swimming in shark-infested waters. She struggles with the limit setting because she really doesn't want to be like her authoritarian father, but eventually is able to grow in confidence in her limit setting to be respectfully and lovingly firm. Good job, Ariel. She says, now I collect empowering information instead of who's its and what's its. So our next case, guys, Snow White. She's a tough one, you can tell. Okay. She's quiet. She doesn't want to speak. She's 8 weeks postpartum. She's not on any meds. Some dwarves in the waiting room are giving you weird looks. Something's going on here. Reluctantly, she discloses that she's plagued by fears of accidentally poisoning her infant through contamination. I wonder where she got that fear from. She's spending 5 hours a day cleaning. As ritual, she makes the dwarves wash their hands. They show her their hands. They wash their hands again, and then they can enter the baby's room. And sometimes then even not. She keeps getting up at night over and over. Every time she lays down to go to sleep, she's like, well, what if my baby stopped breathing? She can't get that fear that her baby's going to go to sleep and never wake up out of her head, and keeps going back into the room. What if this time my baby isn't breathing? Her wise doctor asks her directly and non-judgmentally, you know, some new mothers have thoughts of harming their baby. Has this happened to you? Oh, Snow White answers, I'm so relieved. I've been afraid to tell anyone, but I have this image in my mind of smothering my infant with a pillow. I don't want to do that. I can't get rid of it. I'm so afraid of it. I don't want to hold my baby. I'm not holding her right now. I'm making only Charming and the dwarves hold her because I don't want to hurt her. So let's talk about postpartum OCD, guys. It's actually very common. New onset OCD during the postpartum period, or worsening of pre-existing OCD. Studies estimate prevalence of postpartum OCD of 7 to 11%. Peak prevalence is 8 weeks postpartum. It often leads mothers to avoid holding their infant, so it affects bonding, and they often get other family members involved in these compulsive rituals. And women are very, very afraid to disclose these symptoms due to shame or fear that someone might take their baby away. So this is something where direct, non-judgmental screening is important. Otherwise, you will not find out. Let's talk about that, okay? How do we decrease shame and stigma so patients will actually tell us what the heck is going on? So here are some keys, okay? Normalization. That's, you are not the only one struggling with this, okay? So you're going to ask about something that could potentially bring up shame for the patient. You could say, many women blank, some women blank. Many people are smoking marijuana. How much marijuana do you smoke? Okay, normalization. Lots of education. Education in postpartum OCD that there is not an increased risk of harming the infant. Education to family members. So dwarves, stop washing your hands. Do not enable the compulsive behaviors or help with the rituals. Externalization of the disorder. So separating the OCD illness from the patient's identity as a mother. That is an OCD thought. Okay, that is an OCD behavior. How can Charming and the dwarves and you attack the OCD together versus her as a mother. And connection. I'm telling you guys, this goes a long way. I use this all the time. A patient, I can tell there's something that they don't want to tell me. And I'm just like, hey, I can handle whatever you need to tell me. Remember that. Pause. Silence. Wait. Patients don't like silence, so they feel compelled to fill the silence with something, and you'll get a really interesting answer. Okay. I can handle whatever you need to tell me, and see what happens. Reminding them that they're not alone. I'm with you. I can handle this and I'm with you. And encouraging them, who else do you feel safe sharing this information with? Because shame thrives in secrecy and solitude. It cannot survive the light of open acceptance and human connection. And we can provide that to these people. Let's talk about postpartum OCD versus postpartum psychosis. Postpartum psychosis is a medical emergency and we don't want to miss it. So postpartum OCD, thought process is organized, they make sense. Okay, they don't like the thoughts, they're afraid of harming the baby, they want these thoughts to go away. Postpartum psychosis, also they might be a little bit delirious. The thought process is a little disorganized. The mood changes are present. Their behavior is kind of bizarre. And often the thoughts, they're a little what we call egocentric, right? Like fitting with the patient's beliefs and self-identity. Like a patient might believe that harming themselves or their baby is for a greater good because it's going to protect the baby from some very, terrible pain in the future. Okay. Postpartum psychosis is very scary because there is an increased risk of harm to infant and harm to self. Fortunately, it's rare. Okay. 0.1% of women, but it requires emergency hospitalization due to the risk of suicide and the risk of infanticide. And the first line treatment is lithium. Whereas the first line treatment for postpartum OCD, which is quite common, is reassurance, education, therapy, and SSRIs. I actually learned this while making this presentation, that during the postpartum period, a woman's risk of having the first psychotic episode of her life is 23 times higher than any other time in that woman's life. The postpartum period is a really risky time for women's health, especially when it comes to postpartum psychosis, which, by the way, we believe is related to bipolar disorder. So watch out for bipolar disorder women during the postpartum time. Women with a family history of bipolar disorder who have a history of bipolar disorder are at most risk for postpartum psychosis. Well, a woman who's had postpartum psychosis gets psychotic again. Unfortunately, usually, women with postpartum psychosis have a 50 to 80% chance of having another psychosis or severe psychiatric episode, usually on the bipolar spectrum. So 20 to 50% of those women, possibly that psychosis is limited to the postpartum period. Again, lithium has shown the most benefit. So what do we do for Miss Snow White here? We start her on some sertraline. She's medication naive. We know that sertraline has a huge body of safety data and very little of it gets into breast milk. So why not? It's great OCD medicine. We have to titrate her to 300 milligrams daily. It is a high dose, but it can take really high doses for patients with OCD to respond. We also get her into cognitive behavioral therapy, and she does exposure and response prevention. She labels her OCD thoughts as OCD. She practices doing the exact opposite of the OCD thought. She practices exposing herself to various levels of contaminants. She reads this Everyday Mindfulness for OCD by John Hirschfield, which I think is great. Also, Charming in the Dwarves read When a Family Member Has OCD by John Hirschfield. They stop participating in Snow White's compulsive rituals. They learn, instead of providing her reassurance, they provide her positive affirmations that she is capable of saying no to her OCD and she knows whether something is safe or not for her baby. Also, Brain Lock is a fun one by Jeffrey Schwartz down there. So what about breastfeeding and antidepressants? Okay, this is going to be a whole section on breastfeeding now, guys. It's very interesting. During the first month of an infant's life, their hepatic capacity for drug metabolism is 1/5 to 1/3 of adult capacity, but it increases rapidly. So by 2 to 3 months of age, their hepatic capacity surpasses that of adults. The big take-home message, I'm going to give you a ton of details, but guys, the big take-home message is that for the majority of psychiatric medications, the benefits of breastfeeding on that medication outweigh the risks of breastfeeding on that medication for the majority of medications. Pumping and dumping is not recommended or supported by evidence. There's a couple exceptions here, okay? Clozapine. Clozapine, there's high levels of clozapine in the breast milk, and it can be associated with a granulocytosis and cardiovascular instability. So we avoid breastfeeding while on clozapine. Doxepin has been linked to infant death in one case and respiratory depression in another, so we avoid that too. Okay, there's lots of other options to try for sleep besides doxepin too. So whereas clozapine, unfortunately, if a woman only responds to clozapine, clozapine is it for her. She's going to be formula feeding. Now, the relatively lower concentrations of breast milk ones are sertraline, paroxetine, Cymbalta, mirtazapine. Bupropion, we don't have a lot of data on. Okay, we have a lot on sertraline, paroxetine, less on Cymbalta and mirtazapine. Fluoxetine does have higher levels. It's still advisable to breastfeed. We don't know of any adverse effects in the infants, okay? And we don't want mommy to be changing her antidepressant when she's extremely vulnerable to mental illness during the postpartum time. We don't have data yet on some of the newer medications. And this is just something to think about when you're starting a woman of reproductive age who might be thinking about a family on a new medicine. Maybe go with some of the older medications where you have more safety data than some of the newer ones where we really just don't know. What about ADHD medicine in breast milk? Well, we prefer methylphenidate. Okay. Lower concentrations in breast milk. You do need to monitor for agitation and make sure they're gaining weight appropriately. And both methylphenidate and Adderall may increase prolactin some, which isn't terrible. Okay. So Adderall does have higher rates in infant serum, about up to 15% of the maternal serum level in the infant serum. No adverse events have been found. Clonidine, a little less reassuring. The levels range from undetectable to 66% of maternal serum levels, and there's some reports of hypotonia, seizure, apnea, possible galactorrhea. No data much at all on guanfacine or atomoxetine. What about antipsychotics in breastfeeding? Well, we actually have relatively reassuring data on a lot of them. You got to think about Abilify a little bit because it does inhibit lactation, so it can significantly decrease milk supply. What about sedatives in breast milk? We got some info on trazodone. Only 0.6% of the maternal dose is found in infant serum, no adverse effects. Surprisingly, we don't have much data at all on diphenhydramine and melatonin in breast milk. That would really be really nice to get some. Um, Benzos, we really want to avoid those if we can. Um, if we do have to use a benzodiazepine, we prefer lorazepam because there are lower levels in the breast milk, but they all can cause sedation. And there have been reports of adverse events in infants breastfed with moms on benzodiazepines. What about cannabis? Ursula is back here. There are high milk to serum plasma levels, unfortunately. Okay. It also has been associated with delayed motor development and less frequent and shorter feeds. So again, we should be talking to women about cannabis use. The postpartum period is no fairy tale. So there's so many benefits to breastfeeding in terms of improving the infant immune system, decreasing the risk of sudden infant death, improving cognitive development, decreasing the risk of diabetes and obesity for moms, improving weight loss, protecting against breast and ovarian cancer, bonding. But I want to note that a major source of distress for a lot of women postpartum is when their expectations of breastfeeding are not met by the reality of breastfeeding, and they're struggling to breastfeed. They're struggling with low supply, they're struggling with nipple pain, they're struggling with latching. These women experience a lot of anxiety, depression, and guilt. So while breast milk is amazing and has wonderful benefits, in select cases, we should consider that, maternal mental health for that woman, it may not be right. And some risks associated with breastfeeding may outweigh the potential benefits. Postpartum sexual dysfunction. I see I have some questions. I'll get to that. So let's talk about that, guys. Pain. Studies estimate that 50% of women will experience persistent, that means lasting greater than 3 months, pelvic and genital pain postpartum. And this pain is often exacerbated by sexual activity. Lactation lowers estrogen levels, and that lowers sex drive, and that increases vaginal dryness. Pelvic floor muscle weakness not only causes pain, but nerve damage due to birth and delivery can result in anorgasmia. And then, of course, sleep deprivation, breast tenderness, anxiety. And we also put Snow White on an SSRI. I think that we can be very powerfully healing to our patients when we can ask how they're doing and normalize that sexual dysfunction is very common after delivery. There's also things we can do for these patients, right? She's on 300 milligrams of Zoloft, guys, plus all those other factors, all right? Sexual dysfunction is one of the biggest reasons that patients who should be on SSRIs stop them. So we should be asking about this and treating it. Cialis and Viagra are most effective for having an orgasm. Boost Bar, I think, is most effective for increasing overall sex drive. Well, Butrin is kind of not that helpful, honestly. I mean, it's a little bit helpful. Mirtazapine is a little bit helpful. Okay, I get the most out of the Boost Bar and the Cialis, honestly. Snow White says, no one told me pooping after pregnancy could be more painful than childbirth. That's right. Pelvic floor dysfunction not only causes pain with intercourse, but fecal incontinence, urinary incontinence, severe constipation. That's you're dehydrated due to the lactation. Then you have the pelvic floor weakness and you can have very painful defecation. vaginal and rectal prolapse, back pain, pelvic pain, separation of the abdominal muscles. Women like Snow White are not going to bring this up, and they're going to feel defective and shameful about it. It's important to check in with women for us to be the people who bring up these uncomfortable topics. So, Snow White works with a pelvic floor physical therapist. She really works on her hydration. She takes a stool softener and she gets a squatty potty. Snow White and Charming work with a good couples therapist. Snow White learns to stop treating Charming as another child, cleaning up after him all the time, doing all the chores. Charming learns to take some initiative with household chores. Charming learns not to view Snow White's absence of an orgasm as a failure or a threat to his masculinity. He's able to understand her need for personal space when her breasts are tender, also is not about his failure as a man or a threat to his masculinity. And Snow White is able to approach her sexuality with less shame and communicate assertively to Charming what conditions she needs to start feeling sexual again. Sleep, alone time, Charming doing the dishes, or maybe they hire deer and squirrel house cleaning service. Snow White starts Buspirone 15 milligrams BID with her sertraline, and Cialis 10 milligrams 30 minutes before intercourse, and they live happily ever after. Anyways, and in their new book club is Come As You Are by Emily Nagoski. The Better Sex Through Mindfulness Workbook, A Guide to Cultivating Desire by Lori Brotto. Snow White thanks her treatment team. If you hadn't directly asked me about my pelvic pain and sexual dysfunction, I never would have told you. I would be too embarrassed. I'm so glad you referred me to the pelvic floor physical therapist and helped me understand I wasn't permanently damaged or broken or alone. I thought I was going crazy when I had those thoughts of harming my baby. I was so ashamed and scared. And when you told me that other women have those thoughts and that it was OCD, I felt so relieved to be accepted and seen and know that I wasn't a bad mother for taking medication. Thank you for having Charmin listen to the Motherhood Meets Medicine podcast episode on pelvic floor issues. And he downloaded Come As You Are by Emily Nagoski on audiobook, which made for a great listen while riding to and from our neighboring kingdom. All the villagers love Massachusetts General Hospital's women's mental health website. So, before we go on to Elsa and Anna and Christoph, my favorite case, by the way, I am going to now attempt to give Cipra, Dr. Lada, control. Hi.
Hi. Okay. It's letting me share my screen. Oh, no, it says host disabled participant screen sharing.
This is what I was afraid of, guys. Let's see what I can do. Whoops. Maybe I can find you and change something, Cipra. Do you know what I do? Here you are.
Could you make me host or co-host or just...
How do I, make host.
Okay.
Yes. Excellent.
All right, very good. Now let me get this going on my end. Share screen. Okay. And so everyone should see it in presentation mode now. Is that correct?
I see it.
Perfect. Okay. We're going to do this as a quick intermission. I'm going to take five to 6 minutes. I love the overview that you're giving us on perinatal mood disorders. I think it's kind of a great segue into this. This kind of focuses a little bit more on risk factors that we think about, in an OB office, in a family medicine office, or in a therapy office when the person isn't already seeing a psychiatrist, and how to stratify in our mind, what is risky, where do we want to maybe start getting a little proactive about getting into care, and what are the types of care that might be available to ideally a pregnant mom, not just a postpartum mom, but in pregnancy. So this, you've gone over a lot of the symptoms. I'm just going to briefly talk about diagnosing depression during pregnancy is often hard. Pregnancy and depression have a lot of overlapping symptoms. There's appetite changes, weight changes, disrupted sleep, fatigue, psychomotor changes, sometimes slowing, decreased concentration. And so we kind of understand, why it's not necessarily picked up in a primary care setting, but really highlights, I think, the need for stringent screening, which is starting to happen a little bit more now. At least 6 weeks postpartum, we're screening everyone, and different offices are doing different things around pregnancy screening. The most I've seen is OBs doing screenings, every trimester, or family medicine doing it every trimester, versus usually just 6 weeks postpartum. But if we look at incidence, depression during pregnancy, 12%, and depression in the postpartum period, 22%. In comparison, gestational diabetes is only hitting 4.5% of pregnancies, and hypertension is 5% of pregnancies. And if you think about the screening for both of these, it's like the inverse, right? So for depression and anxiety, we're consistently asking at that 6-week postpartum visit. For gestational diabetes, we're checking at the 27-week visit. We're taking urine at every visit. We're constantly monitoring that. And hypertension, we're taking blood pressure at every single visit during pregnancy. So really a big discrepancy between incidence of, perinatal mood disorders and screening, and incidence of medical disorders and screening. And just want to highlight high risk of relapse. So for women who've never been depressed or anxious, right, 10% of them will develop PPD over a course of a pregnancy. For women who've already been depressed and anxious in the past, 25% will develop PPD. And for women who've previously had PPD, 50% of them, so 1 out of every 2, will have PPD again in the future. So incredibly high. If there's any kind of history of perinatal mood disorders, we definitely want to be on the lookout for that. Some personal risk factors we think about is current abuse, which we don't often ask about in medical settings. So currently, are you feeling unsafe in your relationship? Are you feeling unsafe in your home? Is there any abuse that's going on? A history of trauma, early childhood events, like Dr. Greeter said, things that sometimes have happened in the past, traumas that have been buried, suppressed, repressed, come up during this period. If we think about postpartum psychosis being 23 times more common or at risk in that postpartum period, think about every vulnerability is really expressed and highlighted and amplified during that pregnancy and postpartum period. And then the other things that we want to think about are medical complications during pregnancy. So high risk pregnancy or chronic medical problems, women are at significantly higher risks for developing perinatal mood disorders. So almost anyone that is seeing a maternal fetal medicine specialist for some condition during pregnancy that just requires increased monitoring, we really want to be thinking about screening them aggressively for perinatal mood disorders, or even if we're not doing a whole screening, at least asking consistently, and not necessarily over normalizing it, which is yes, pregnancy is stressful, life is stressful, I'm sure you're feeling stressed, but really kind of getting in there in the nitty-gritty and understanding what is the nature of the stress, how consistent is the stress, right, as we refer to it, what kind of dysfunction might it be causing, and how chronic has it become. And then lastly, history of psychiatric illness, especially in prior pregnancies, which I already covered. Other kind of social risk factors to think about: marital dissatisfaction. That is a big one, and that's not often one that we talk about. Sometimes when we are screening for outright trauma or abuse, we're not necessarily, and that might be negative, we're not necessarily asking them just how they feel about their relationship, but how they feel about their relationship, if they're in a relationship, can have a lot of impact on their risk for developing PMDD, inadequate social support, childcare, stress. If the pregnancy was unwanted or unplanned, that also sometimes becomes a difficult topic if the woman has decided to continue the pregnancy and clearly they are pregnant and going through the pregnancy, but really understanding kind of the origins of the pregnancy and how they might have felt about it in the beginning and how they might have made decisions around that is important. And sometimes, you know, we assume a lot when we even come into the rooms in medical rooms and say like, congratulations, you're pregnant, without maybe even making room for people to talk about how they actually feel about the pregnancy. And then lastly, and this is one I really, really relate to, I had a set of twins who had colic, and that was 8 years ago. I will never forget it. It has left an impression on me for the rest of my life. Difficult infant temperament. That's also something that we don't often talk about. So the fussiest times in the newborn period tend to be between 6 and 12 weeks postpartum. It's a time that we sometimes see purple crying or colic. Colic can look anything like a baby just being fussy all day long. It can look like prolonged crying at certain periods of time. My twins would cry from 7 p.m. to midnight every night, like clockwork. Oh, I'm there. Hold on, let me close the door. From 7 p.m. to midnight every night from week 6 to week 11, and it was predictable. It was horrible. And it was something that no one ever asked about, but a woman's predisposition, even fathers and, you know, caretakers' predisposition towards perinatal mood disorders is often directly correlated to the temperament of the infant, and so something that we should be asking about regularly. So high yield questions, asking specifically about past suicide attempts, any thoughts about suicide. Myth that we sometimes have is asking about it will make it happen. That's just not true and evidence-based. Specifically, as Dr. Greeter said, asking about drugs now or in the past, you know, coming in with normalizing statements so that people feel more comfortable opening up and disclosing use if they are using something. And just talking about whether people have ever been on medication for their mental health. I know that a lot of the time in clinical practice for me, you know, people come in and say, no, I've never been depressed or anxious, or I never had any kind of mood disorder. I'm just feeling the way that I'm feeling now. But when I ask them, well, have you ever been on an SSRI or anything like that? Then it's like, oh yeah, well, you know, when I was 22 and I was in college and I had a bad breakup, I took an SSRI, but they don't necessarily correlate that to having a past episode. So that's an important way to sometimes ask. And then in the postpartum period, you know, asking direct questions around, are you able to sleep when the baby sleeps? So that's one of the like highest indicators of postpartum anxiety. When baby is resting, is mom able to actually rest, or is her mind spinning? Is she trying to get things done? Is she feeling on edge and anxious? And so it can be hard to kind of understand what's going on with sleep in the postpartum period because babies are often waking up all night long, but usually mom is really tired. And so if baby is sleeping, but mom is not sleeping, we really want to understand a little bit more about what's going on there. And then asking questions like, do you feel helpless or hopeless? Do you feel things like, even if people aren't openly suicidal or having suicidal thoughts or planning for suicide, but more subtle thoughts like, do you feel like life is not worth living? Do you feel like you're a burden to people, to other people, to your baby? Do you feel connected to your baby? And then asking directly, are you having like moments of pleasure with your baby? Are you enjoying your baby at times? Because things can be going fine, you know, babies being burped, fed, putting on weight, sleeping, but there's no enjoyment there. And that would be another thing that we would start to wonder a little bit about, that bonding experience, and like anhedonia as a specific symptom of depression, as opposed to just tired mom. So I won't go through this entire chart in detail, but I like to think about risk stratification in the pregnancy and postpartum period, kind of thinking both about risk factors as well as what interventions we can utilize. Often right now in our current landscape, there's like on and off, right? So either mom is fine, or we're treating mom like she's fine, or we're not asking the questions, or we are asking the questions, but it's kind of subclinical. And then I'm so sorry. Where can you get her, please? Sorry, my kid's coming into the room. No. All right. So either it's kind of subclinical, we haven't asked, OB thinks that the patient's fine, family medicine thinks the patient's fine, they're kind of like cruising through their medical appointments and we're saying everything's good. And then suddenly mom has symptoms, she's crying in someone's office, you know, and all of a sudden it kind of becomes this pathway to, she needs to see someone right away. She can't get an appointment. Everyone's booked up. Everyone is, private pay, whatever the things are, which then leads to a lot of distress on mom's part, often on that family unit, often on the medical provider that's trying to take care of mom, which is things turn from fine to an emergency. And that's really not how it is. And it's not how it has to be. So my big bend is really around like following symptoms closely and using risk stratification so we don't end up in that situation and we're not building these cycles where this is what continues to keep happening. So we think about low to mild risk. If there's no previous history of mental health issues, there's no persistent symptoms, just occasional symptoms that come and go. Even at that point, if there's symptoms that come and go, we still want to be referring to like support groups. We want to get people into even online-based coaching or just asynchronous perinatal wellness classes, so that they can start to kind of prepare themselves for the stresses that are about to occur. If there's symptoms that are coming and going, that's not, unfortunately what happens is we say like, you're fine, go off and it'll be okay. But that's actually not a time that we want to not use that opportunity to give a woman resources, preferably really early in the pregnancy. And we want to make sure that we are continuing to screen in subsequent trimesters. So in moderate risk, I think about people with previous history of mental health issues. They might not be symptomatic currently. Those are people that we really want to be like following closely, maybe not getting into services right away. Patients who've had previous experience of abuse, even if they're not symptomatic currently, again, we need to be following them closely. Or, no prior history, but their current symptoms are somewhat persistent and occasionally causing dysfunction. And those are patients that we really do want to be referring into individual therapy. We want to just kind of have it on their radar to be giving them information about medication, or at least information about a medical evaluation, even if they're not doing it at that point. And we want to be really proactive about behavioral modification, and using partner inclusive models and coaching. So behavioral modification is just some basic CBT interventions, as well as like preparatory behavioral interventions for the end of pregnancy and for the beginning of that postpartum period. So thinking about things like time blocking, taking turns with feeding the baby, coming up with a proactive plan around rest for everyone, coming up with a proactive plan around therapy after the baby is born or during the end of the pregnancy. What often happens is like the 6 weeks goes by, it's really difficult. Now you have a new baby, the baby's crying all the time, the baby has needs, you're really tired, you're struggling, and then you're starting to try to think about, how do I even start to make an appointment? Or, I do feel like I need meds, where do I even start with a medical evaluation? So that's really stuff that we want to kind of get in place with resources way ahead of time. And then finally, if people are at high risk, so they have persistent symptoms right now, they have marked dysfunction right now, they have a history of significant illness, even if they are not currently having symptoms, like if they've had postpartum psychosis in the past, we would prefer for them to be in medical care from the beginning, or like screenings or anticipatory guidance. And so those people should be following closely with OB in collaboration with with psychiatry in collaboration with their OB, and should be in psychotherapy. So that's kind of how we think about it. And then just 2 more slides here. I'm trying to get through this quickly. We also need to think about like detection and access to care. So right now we use the Edinburgh. The Edinburgh was developed in Scotland in 1987. So I and the Edinburgh are almost the same age. So it is old, and it is clinically validated, and it is really the only screening tool that we use consistently right now. But it's not without its problems. And I think knowing some of these problems can be helpful even when we're interpreting the Edinburgh, when we're giving it out, or when we're kind of thinking about what screening looks like in these different care settings. The Edinburgh does utilize questions that rely on insight, which is not necessarily there when someone is depressed or anxious. The questions are not necessarily short. So we, in talking to our patients about this, we might think about using short questions, or even using a modified Edinburgh that just takes away some of these propositions, and utilizing utilizing questions that have different cultural frames. So very quickly, looking at like a copy of the Edinburgh that I put here. Number 3, I blamed myself unnecessarily when things go wrong. Someone is significantly anxious or has postpartum anxiety, they're not necessarily able to see that they're unnecessarily blaming themselves or that their feelings are unnecessary. They just might not have that insight. It's the same with number 4. I've been anxious or worried for no good reason. Well, if you have significant postpartum anxiety, going to checking if your baby is actually breathing 7 times a night might not feel like no good reason. It might feel like a really important reason. The same with I felt scared or panicky for no good reason. So a lot of these questions, it's old in the way that it's written. There's like multiple prepositions, even number 6. I feel like things have been getting on top of me, and then like the answers. So just knowing that this is a screening tool we're using, understanding some of its limitations and where some people might get lost, I think is important. We don't have a new one yet, but just kind of like important to understand what we're utilizing. And so this is the exciting part of my slides, which is what can we do to actually increase detection and access to care. So one of the solutions that we're working on right now, and there's lots of different variations of this kind of solution, but I think something that we need to be like aggressively as people in the perinatal field and people who are having any kind of contact, whether medical, therapy, psychiatry, related contact with pregnancy or postpartum period, is what can we do to help integrate solutions together and work together so pregnant and postpartum people are not having to go all over town and really advocate for themselves to get into services, but that we are cohesively screening, referring to each other, getting help when patients need it, and really getting a lot of that preventative care put together rather than, again, crisis postpartum care, which often doesn't go well. So our current situation, most OB offices are using paper Edinburghs. When anything is done on paper, it's not necessarily getting followed up on. An OB is like tabulating, or family medicine is tabulating and telling the women they need to seek care. And that's kind of where that discussion ends. So one way we have started to work around this is that we have like therapy and psychiatry units that are assigned to OB offices, and OB offices have screening tablets that are actually connected to behavioral health, so that Edinburghs and other screening tools, whether it's PHQ-9s and GAD-7s, can actually be done on screening tablets in OB offices, in family medicine offices, through behavioral health integration. That way, the mental health information is, coming through the hands of the OB, but going directly to people who are going to outreach women, offer education, offer resources, start that process much earlier in the game, and then be able to nurture women throughout the pregnancy with intelligent touch points, and being able to then consistently monitor symptom progression, symptom escalation, and again, be able to intervene with kind of like the lowest level of care rather than symptom escalation, high level acuity, lots of risk, and then struggling to get into appointments. So I'm going to go ahead and stop there. If anyone wants to talk more about behavioral health integration around the perinatal period, I would be happy to talk, to discuss. I'm going to put my email in the chat to reach out to me. But otherwise, Dr. Breeder, I'm going to hand it back to you.
All right. So now I have to change it back to me somehow. Okay, hold on. I go to participants. How do I become the host again? Or can I just, host disabled participant screen sharing. Do you have to make me host, Cipra? Dr. Lotta?
That is a good question. Let me see if I can do that. If you tell me how you made me host, I can probably just go ahead and make you host. Oh, here we go. Make host.
All right. So I should be able to share my screen again. It looks like it's working. Oh. Phew. Okay. Let me get back to where we were, okay? We were about to do almost there. Thank you guys for your patience with us. Elsa. All All right, my email is at the top of this PowerPoint, by the way, if you guys need me to. And I love if we could discuss at the end how to improve communication and collaboration between OB-GYN and psychiatry and support you guys better too. Thanks so much, Dr. Latta, and for the ingenious things that you're doing to help streamline those patients getting care. So Elsa, here we go. 30-year-old, never pregnant, struggling with severe irritability, hopelessness, anxiety, interpersonal conflicts. There's a lot of feedback, by the way. Someone needs to mute. Someone is getting a lot of feedback here. Awesome, thank you. No, wait, there's still feedback. Okay. Interpersonal conflicts about 10 days prior to menstruation, peaking 4 days before menstruation, and resolving with menstruation. One second. Josh, can you tell me how I mute all participants, please? I know there's a way. Uh-huh. All right, mute all. Yes, you can unmute yourselves, but now you're muted. All right, yay, I got rid of the funky noises. Sorry, guys. All right, so PMDD. What is PMDD? It's very common, affecting about 3 to 9% of women, and causes marked impairment in functioning. For the diagnosis, you have to have at least 2 consecutive months for at least 5 of these symptoms. Okay. And this is severe irritability, emotional lability, anxiety. It can be depressed mood, hopelessness, low self-worth. And it resolves completely with the start of menstruation during the follicular phase, if it's PMDD alone. So the symptoms only occur during the luteal phase from ovulation to menstruation. Usually they're at their worst 2 days before menses. If the symptoms are present outside of the luteal phase, okay, during the follicular phase 2, we actually call that PME, premenstrual exacerbation. Sometimes women can have premenstrual exacerbation of their depression, their major depressive disorder, or bipolar disorder, and also have PMDD. How would that work? It would work if you'd have to figure out if the symptoms during the luteal phase are maybe distinctly different than the symptoms outside the luteal phase. For example, if during the luteal phase there's intense irritability in a woman who generally has depression outside of the luteal phase, but not like irritable, angry, yelling, screaming, labile, then she might actually have both PME, exacerbation of her depression, and PMDD, premenstrual dysphoric disorder, during that luteal phase. So you have a woman keep this crazy intense record of her symptoms to make the diagnosis. That's an example of one of them. The first line treatment for PMDD, SSRIs. It's interesting that a lot of women will want hormones first, because I think that there's less stigma to taking hormones, because then they're like, oh, it's a problem with my hormones. It's not like a psychiatric illness, right? That feels better. But actually, SSRIs tend to work better and have less side effects than oral contraceptives as the first line treatment. The SSRI doses that we use for PMDD treatment, you can actually get away with lower doses than what you use for major depressive disorder. So you could get away with like 10 or 20 milligrams of fluoxetine instead of like 40 to 80 milligrams of fluoxetine. You could also get away with just taking it during the luteal phase. And some women really like to do that because they don't like the sexual side effects. paroxetine, sertraline, fluoxetine are FDA approved for PMDD. Yaz is the oral contraceptive that's shown efficacy in randomized controlled trials and thus is FDA approved. It's quite likely that other contraceptives also work for reducing PMDD symptoms. They just didn't go to the trouble of getting the FDA approval. It is also possible that Yaz works a little better because it has a shorter placebo pill duration. I have a lot of my patients skip the placebo pills in their combination oral contraceptives to optimize emotional regulation. And then leuprolide, gonadotropin releasing hormone agonists are kind of like reserved for those non-responsive to SSRIs and contraceptives because of all the side effects they cause. I didn't know before I did this presentation that calcium, 600 milligrams twice daily, can have a mild effect. B6 supplementation, though you don't want to go higher than 200 milligrams a day due to risk of neuropathy. Magnesium, vitamin E, and reducing caffeine and alcohol can help. Side note, for physicians who want to learn how to prescribe contraception, like I believe as a psychiatrist, I'm going to do this module myself because I feel like it's very difficult for patients to access contraception. And if I can be a part of making it easier for them to get contraception by educating myself, I think that's a great service, you know? And so, you know, other physicians attending this PowerPoint who might be psychiatrists, for example, who want to learn about that, there you go. This is a free website, National Curriculum in Reproductive Psychiatry. She has a lot of topics on there. All right. So Elsa tracks her mood symptoms for 3 months. We confirm her diagnosis of PMDD. She starts Prozac 10. She needs to go to 20. She's starting to feel a little better, but you get this frantic phone call from her sister. Uh-oh. So Anna's talking on the phone. After starting that new medicine you prescribed her, Elsa is not acting like herself. These past 2 weeks, she only slept 2 hours a night. She's talking so fast, I can't understand her. I mean, this is not my sister. My sister is usually so reserved, and she's going around wearing more revealing clothing. She turned our entire kingdom into ice. I think she's out in the snow singing to herself right now. Uh-oh, guys. So, screen for history of manic episode before prescribing an antidepressant. How do we do that? Yeah. Okay, what is a manic episode? It's high self-esteem, intense euphoria or irritability, doing risky stuff that is out of character. Okay, now contrast this with Ariel, right? So Ariel has impulsive, risky behaviors, talks fast, but that is her baseline, and that is ADHD. Okay, if it is their baseline, it's ADHD. So this is out of character for them. It is an episode that is out of character. Not needing to sleep. So not just like, oh man, I wish I could sleep. I just can't fall asleep. No, like I don't need sleep. I'm good. I'm not tired. I'm great. I'm going to go clean the house. Increased activity, feeling invincible, often have hallucinations. So different from mood swings, right? Like mood swings last hours. A manic episode is days. Okay. Decreased need for sleep, like being able to go many nights with very little sleep and not feeling tired, I think is a big red flag, by the way. So, and if you're suspicious, consult a family member. Patients are often not going to tell you that they've had a manic episode unless you directly ask, because manic episodes are fun, they feel great, and most of the time someone with bipolar disorder is going to show up depressed, not manic. So this is easy to miss. So what do we do for Elsa? This is a little complicated, guys. We start her on olanzapine. causes a lot of weight gain, but man, it'll get you out of a manic episode or a psychotic episode fast. So we start her on the olanzapine because it works faster, and we start the lithium 600 milligrams at bedtime. We get a lithium level 5 days later. Our lithium level is 0.4. We go up to 1200. The lithium level is 0.9. She's starting to get not manic anymore. So, we gradually taper that olanzapine to minimize long-term metabolic risk, but she gets depressed. We do lamictal, which is slowly to avoid Stevens-Johnson syndrome, titrated to 200 milligrams at bedtime. And unfortunately, she's getting some breakthrough hypomania. We switched the lamotrigine. We traded out for some quetiapine, titrated to 300 milligrams QHS, and we give her some metformin, 500 BID, to decrease that weight gain on the quetiapine. And when we achieve a period of 6 months without mania, right? I'm going to call that the maintenance phase there. We're going to reduce the lithium. I used to think about targeting a lithium level of 1.0 as ideal, but it's not for the kidneys. So it's actually more ideal in the maintenance phase to target a lithium level of like 0.6 to 0.8 to protect those kidneys. It's kind of funny because I have a patient right now who is on lithium 1050 milligrams QHS with the level of 0.7, and sometimes you just got to make weird doses, guys. It's hard to fully treat a bipolar patient. I know I would love to do it with just the lithium, but it's hard. Most patients with bipolar disorder are going to need 2 meds. They're going to need an atypical antipsychotic and a traditional mood stabilizer. Whatever you do, please don't try to treat these patients with just an antipsychotic. Usually doesn't go well for them. It usually doesn't keep them stable. In addition, we provide Elsa, and also notify her closest family member, Anna, about an emergency supply of olanzapine. So we designate a family member as the point person she trusts to know where this olanzapine is. And if she starts to get hypomanic, she immediately takes her olanzapine 10 milligrams and calls the office. So we counsel them about warning signs. I think that this is a great strategy. It's very hard for patients to reach out, especially when they're hypomanic, and call us. So knowing that there is a medicine they can take, to quickly kind of get them out of that danger zone will really avoid hospitalizations. We monitor her creatinine, her GFR, her TSH, her A1C. Actually, we need to monitor PTH because you can get hypoparathyroidism as well as hypothyroidism on the lithium, and a yearly EKG. And that's that. So PMDD and bipolar disorder commonly co-occur. The average age of onset of the first manic episode in women is age 15 to 23. So data actually suggests women with PMDD have 8-fold higher risk of bipolar disorder than other women. So women with bipolar disorder are more vulnerable to severe mood symptoms in response to hormonal fluctuations, and are more likely to experience mood side effects of oral contraceptives. So you're going to see a lot of bipolar disorder women in your clinic, probably if you're an OBGYN. Watch out, because they won't come in looking manic, but they will get manic. In addition to medicine, we have Elsa read the Bipolar Disorder Survival Guide, and she participates in an online bipolar disorder support group through, this is a free service, by the way, guys, the Depression and Bipolar Support Alliance. Anna and Olaf join NAMI, National Alliance for Mental Illnesses, family to family class. And sometimes Christoph and Sven come to. Her doctor explains the importance of regular sleep, avoiding caffeine, the medications that interact with her lithium, like NSAIDs, the signs of lithium toxicity, and make sure that a release of information is signed for a close family member to be able to reach out if she gets in trouble and she starts to get manic, and for her therapist. So communication with the family is going to be really key with these patients in particular. Elsa and Anna enjoy that validation and the sense of not being alone with this in their bipolar and depression support alliance group so much that they decide to join a local DBT group together. Anna says, after completing the interpersonal effectiveness module and using the Dear Man skill, Elsa and I can communicate assertively about difficult topics and respect each other's perspectives. Elsa, I just completed the distress tolerance module with mindfulness and my radical acceptance DBT skill. Now I can really let it go. DBT for everyone, guys. Olaf, I love warm hugs and engaging my five senses. He's good at mindfulness. So now let's talk mood stabilizers and pregnancy and breastfeeding. Lithium, it's gold standard for bipolar disorder. There is a risk of Epstein's anomaly. It's a 1 in 1,000 risk. Thus, we need to keep in mind that 99% of lithium-exposed infants will not develop this cardiac defect. But given, if you think back to the slide we showed before about relapse rates of illness during pregnancy, about 80 to 85% of women with bipolar disorder who stop their medicine will experience the illness of bipolar disorder during their pregnancy, relapses in their illness. So if there's a pregnant woman who's stable on lithium, we recommend that she stay on her lithium. In fact, the dosage may need to be increased during pregnancy because the volume of distribution is greater. Lithium should be held with the initiation of labor because of the severe fluid shifts she undergoes. She can get lithium toxic. And then you resume the lithium at the same pre-pregnancy dose upon delivery. It's a little tricksy. Lithium and breastfeeding is a complicated decision. There isn't a right answer. It is possible to safely breastfeed while on lithium, but it requires a lot of monitoring of the infant, monitoring them for dehydration because they can get lithium toxic fast, monitoring them for lethargy, hypotonia, decreased renal function, okay? There's a small study they did at MGH on 10 mother-infant pairs, and the lithium concentrations in the breast milk range from 17 to 73% of maternal serum levels. Infant serum lithium level averaged about 0.15. No adverse events, except there was like one infant that had an elevated TSH and the TSH normalized when the mom discontinued lithium. I really think that women should consider supplementation with formula feeding if they're going to try to do this, so that the baby's getting the benefits of the breast milk, but we're making sure they don't get dehydrated and lithium toxic. Also, a bipolar woman needs to really be careful during the postpartum period, because sleep deprivation is a major trigger for manic episodes and depressive episodes. So supplementing with formula feeding in a bipolar woman allows the partner to do some feeding. Lamotrigine. Previously, there were concerns about increased risk of cleft palate, but newer, larger meta-analysis did not find an increased risk. Okay, this is a population-based study of 3.9 million births, okay, and a meta-analysis of 21 studies. So that's cool. It is a tricksy bugger to dose during pregnancy. Estrogen induces the liver enzymes that metabolize lamotrigine. Be aware of this because, by the way, this works with birth control too. If you put a woman who is taking lamotrigine on a combination oral contraceptive, her lamotrigine level could decrease by 50% and she could destabilize. Okay, so if possible, we recommend, if possible, get a lamotrigine level prior to pregnancy when she's stable, and we're like, oh, that's a good effective dosage. And one strategy, right? One strategy is measuring a blood level every 4 weeks and increasing the Lamictal dosage by 20 to 25% at a time. As you notice the Lamictal blood level dropping, and then after delivery, you're doing the reverse, you're measuring the Lamictal blood level, and then you're decreasing the Lamictal dose. So it's a little complicated, but relatively safe during pregnancy. Breastfeeding, more controversial. We do see higher serum levels of lamotrigine in the breast milk. No adverse events no adverse effects, have been reported. But adverse events could include low platelets, one case report of apnea. Fortunately, no Stevens-Johnson syndrome. So you'd have to really closely monitor the infant, and this is really more of a gray area, okay, when it comes to lamotrigine and breastfeeding. No clear right answer. Now, good news, atypical antipsychotics. So now there's this national pregnancy registry for atypical antipsychotics. Your patient can participate, if they'd like to, put their data in there. So far they have 640 live births exposed to atypical antipsychotics in there. And we're not finding any significant difference in birth defects. Quetiapine, we're particularly excited about because there was a large enough number of women in this registry taking quetiapine that we could take that data out and look at quetiapine by itself and see there's no increased risk of birth defects. Also, fun fact, quetiapine is a very large molecule, so little of it gets into the breast milk. So good news on that front too, but we do need to warn women about small increased risk of gestational diabetes on atypical antipsychotics. Small, but there. So for breastfeeding, this is a review, but I like this cute baby on this slide, so I didn't want to delete the slide. So avoid clozapine, reassuring data on olanzapine, quetiapine, risperidone. We don't like Abilify because it's going to decrease their milk supply. And we don't got data on some of the newer stuff like Latuda. Depakote. Yeah, we all kind of hate Depakote because there's like 3 to 5% risk of neural tube defects, malformations of the heart, limbs, and genitals. So we try to avoid Depakote in women of childbearing age. And some women, that's the only option. And then we're going to be counseling them about contraception. If a woman gets pregnant on Depakote, at least take 4 milligrams of folic acid daily to decrease risk. Prenatal exposure to Depakote may also be associated with lower IQ and risk of autism. But Depakote is relatively safe during breastfeeding. Okay. In fact, fun study, one found that higher IQ in infants breastfed while the mother was on Depakote than infants formula fed while the mother was on Depakote. So yay, breast milk. Might ask, well, should we have the woman with bipolar disorder on lithium during pregnancy and then switch her to Depakote while she's breastfeeding? I'm going to vote no on this one, guys. I will tell you why. Okay. Again, everything in this presentation, we're weighing risks and benefits here, and there isn't a clear right answer. But if a woman has been stabilized on lithium, right? Lithium works for her. The riskiest time for that woman is going to be the postpartum time. We do not know whether or not Depakote will work for her. Changing medication during pregnancy and during the postpartum time, we really try to avoid it. So I personally would not switch meds during that time. Then Elsa says, I want to freeze my eggs. Look at her. She's freezing her eggs. She's doing the IVF stuff. If only it were as magical and easy as Elsa makes it look, guys. We are now going to talk about infertility. Anna and Christoph face infertility. So we're helping patients facing infertility to grieve the loss of what we call the reproductive story. That is their hopes and dreams and their identity of themselves as how they would become a parent. So Anna tells us some about her reproductive story. As far back as I can remember, I thought about becoming a mother. I stuffed pillows in my shirt and played with dolls. I promised myself that I would be there for my little girl and never leave her alone like my mom did. I wanted to honor my mother by becoming a mom myself. So there's some very common themes in the reproductive story. You see that this is part of a person's fundamental identity. And so the experience of infertility can often result in a fragmentation of self and loss of identity. Anna talked about the desire to overcome the loss of her mother by becoming a mother and making sure she was there for a biological child. That's a common theme, that parenthood presents an opportunity for self-development, growth, and healing of trauma that infertile couples are longing for and may have lost. Women often feel less feminine, men less virile. Patients often feel kind of psychologically stuck as neither a child and not an adult yet either, because they're not a parent. So patients are mourning not just a potential child, but missed opportunities for self-development and their entire identity prior to the trauma of infertility. Anna tells us, I faced down giants. I saved my kingdom. I rescued my sister from herself. But I can't make this happen. Maybe I'm not trying hard enough. I used to be so strong and now I feel so weak. So it's very common that patients see infertility as a psychological failing of not wanting or trying hard enough instead of a medical condition. Unfortunately, historically, psychiatry believed that infertility was caused by a woman's ambivalence about becoming a mother or unresolved issues and conflict with her own mother. So there's unfortunately, some of that is still embedded in our cultural belief system. As a therapist or doctor, you can help by helping a patient understand that infertility is not a skill that you just haven't mastered yet. Fertilization of an egg and sperm is a biological process you do not control. It has nothing to do with your psychological mindset. I also want to note that infertility especially impacts female physicians. Okay, so rates of infertility are about 10 to 15% of couples of reproductive age. 25% of female physicians are impacted by infertility, much higher percentage. And these successful women, yes, think when I work hard at something and I do the something right, I am successful. Therefore, I must be doing the something wrong. I must be to blame. And that is deep within them emotionally, even though rationally they may not know that, they may know that that's not true, it is in there. I really like this book. I'm going to quote her like 3 times in this PowerPoint because I was reading it while writing this PowerPoint. Reproductive Trauma, Psychotherapy with Infertility and Pregnancy Loss Clients by Janet Jaffe. She says, these patients are not unlike soldiers who repeatedly are sent back into battle to conquer the same ever elusive hill. Anna continues. I know Christoph loves me and it makes no sense, but I can't stop thinking he deserves to be with someone who isn't barren. When we try to make love, I just feel so tarnished. I was never insecure like this before. It's crazy. Well, I got news for you. It is not crazy. It is 100% human. Patients feel guilty. They wonder if their partner will still love them if they can't produce a child. Men feel helpless. They can't fix this for their partner. Okay, so our job here as clinicians is to normalize this. That is powerfully therapeutic, to tell these women and men that the insecurity, the vulnerability that they are experiencing is normal when they're experiencing the trauma of infertility. It's powerfully therapeutic for them. We have to lean in here, lean into your patient's pain, even though it is uncomfortable. It takes courage. A lot of times, well-meaning clinicians, friends will minimize, oh, it's not that bad, or invalidate because they are uncomfortable with the patient's pain. So it's important to give them permission to be in pain. That patients commonly feel anger and envy when they hear of a friend's pregnancy, and then they feel guilty and shamed. How could I ever think and feel that? And you tell them, that is because you are human. You are grieving. You are sad for yourself. They may need to avoid a baby shower or family gathering, and they feel like a bad friend because they're avoiding it. They're doing seemingly innocuous things like getting milk at the grocery store, and oh my God, I'm in the baby aisle and I feel devastated in an onslaught of painful emotions out of nowhere. They often describe a roller coaster of renewed hope about the next fertility treatment and then bitter disappointment. So really our role here, validating them and getting them the proper resources, is key. So what are we validating? We are validating that it is 100% normal and human to feel angry, afraid, inadequate, envious, like a failure, defective, and helpless. I like this quote. I want people to know that every pregnancy announcement is devastating, not because you're not happy for them, but because you're sad for you. It's very isolating. Women feel surrounded by their peers who are starting families, and their peers are talking about their families and focused on their families. And every time there's a family gathering, there's kids there. So there's both that need for connection, but need for connection with people who are also a reminder of what they're missing and lost. So it's very challenging for these patients. Let's also talk about early pregnancy loss. People know that this is common. It affects up to 25% of pregnancies, but it is not benign. Women who have lost their pregnancies are twice as likely to report anxiety and 4 times as likely to report depression. And who's following up with these women? They've lost their pregnancy. They're not seeing an OB anymore. They don't have a pregnancy. So these women who are extremely vulnerable to depression, anxiety, and PTSD are often not seeing anyone. The if-onlys that would-be mothers ruminate on can fill an entire book. Rationally, these women know that they did nothing to harm their baby, but emotionally they feel they must have done something wrong. I found a lot of great resources on the pregnancy and infant loss support website there that I included. So we listened closely to Anna. We let her share with us her loss. Another quote from that same book. on reproductive trauma. Reviewing both the obvious and the less apparent losses with patients will make clear the enormity of the trauma they have experienced and help them understand the depth of their pain. The challenge for clients is to acknowledge that these losses have forever changed them. They are not the person they once were, and to incorporate these losses into a new sense of self. I basically take that to mean it is only after patients understand the enormous impact of their loss that they can fully then mourn that loss. So we help them rewrite the reproductive story with a new ending. Therapists can help their patients try on different options for building a family. Should the story end with adoption? What if the story ended with an egg donor? What if the story ended with you choose not to have children, right? And they kind of try them on and see which one sounds best. It helps each partner in the couple to articulate what they need from the other partner to overcome the trauma so they can grow and bring into being a new possible self. So Anna develops her identity as a ruler. She spearheads social justice programs, empowers women in her kingdom, improves relations with Indigenous peoples, and addresses systemic racism. This fulfills her need for generativity, and she considers this her legacy to future generations. Christoph finds meaning and fulfillment by starting a school and foster program for orphan rock baby trolls. He values this opportunity to give back to the rock troll community who adopted and fostered him as a child. Unfortunately, IVF efforts to obtain donor eggs from her sister Elsa are unsuccessful. Though unable to produce a biological heir for the kingdom, Elsa and Anna decide that it is time to evolve from a genetic monarchy to an electoral government anyway, Olaf says. And that's what we call post-traumatic growth. A brief aside on the psychiatric side effects of the infertility treatments, there's a lot, okay? A lot of emotional side effects from the infertility treatments. I really want to emphasize that there's so much focus on an infertile woman being able to achieve a successful pregnancy. There's a lot of focus on that outcome. Both women and their partners and their clinicians may be surprised that these women who become pregnant, who have struggled with infertility, still have anxiety and depression after attaining a successful pregnancy. That is because obtaining a successful pregnancy does not undo the trauma of infertility. It's harder for these women to seek treatment. They feel that they don't deserve to be depressed because I'm finally pregnant. I finally had a baby. I don't deserve to be unhappy. They feel ungrateful. So really be on the lookout, because accomplishing a healthy, successful pregnancy does not undo the psychological trauma and pain of having experienced the process of infertility. And these women do need treatment. Birth trauma. That's a great medieval painting of a C-section for you guys. So 40% of women describe their birth as traumatic. About 5 to 6% of women do meet criteria for ongoing PTSD following birth. It's particularly sad because, like other traumatic events, there's going to be reactivation of symptoms on the anniversary of the event, which happens to be their child's birthday. The PTSD following birth can lead to avoidance of their infant, avoidance of using healthcare resources, decreased bonding, nightmares, marital strife. To mitigate risk, we should think about open communication with the woman in labor, putting the locus of control on the patient as much as possible, skin-to-skin contact with the baby, and social support after delivery. A whole nother PowerPoint could be made on treating birth trauma, but hey, if you want to know some more about it, check out Dr. Cheryl Beck's research on the treatment of birth trauma. I want to go back. Here we go. So there's some great books. This is the one in the corner that I quoted 3 times. That was kind of really into while I was making this PowerPoint. The National Infertility Organization has a lot of resources. She also has a video. The woman who wrote this book has this great video online about infertility and pregnancy loss. I really like Dr. Anna Glazer's Mind Body Pregnancy podcast. And the Motherhood Meets Medicine podcast has a great episode on infertility. And here are some PTSD after birth resources and pregnancy and infant loss support website. Finally, fairy godmother, mental health and perimenopause. Bibbidi bobbidi boo. Because the SWAN study, which is a huge study of women's health across the nation, estimates that up to 39% of women have depression during perimenopause. It's a really high risk time. Earlier onset of menopause and past history of depression are major risk factors. So there's a prospective study at Harvard where they followed women over time. The women who started perimenopause during the study were twice as likely to have depression than the women who remained premenopausal during the study. Antidepressants help with both the mood and the vasomotor symptoms. Side note here, antidepressants that are strong cytochrome 2d6 inhibitors, Prozac, bupropion, paroxetine, inhibit the conversion of the breast cancer drug tamoxifen to its active metabolite endoxifen. I know that I personally treat a lot of breast cancer survivors who take tamoxifen. So we, using a strong cytochrome 2d6 inhibitor can render their tamoxifen less effective for preventing their breast cancer reoccurrence. So you think about, we prefer using one of the antidepressants that isn't a strong cytochrome 2d6 inhibitor. Perinatal mental health in Black mothers. This really needs to be addressed as a huge disparity. Black women are 3 to 4 times as likely to die of pregnancy-related causes than white women. Also, Black women, they get a double whammy here because they are more likely to have perinatal mood and anxiety disorders and less likely to receive psychiatric treatment. I liked this interview on Dr. Anna Glazer's podcast about this issue. So really more needs to be done in terms of decreasing stigma and improving access and improving the comfort that helping Black mothers get appropriate psychiatric treatment. And for the parents who are not represented by the traditional cisgender heterosexual Disney couple, there is not a lot of information on trans men and their pregnancies. I found this review article and I thought it was pretty good. And it did talk some about, it's very hard because these trans men, they're like, should I try to pass as a cis pregnant woman, or do I try instead to be a pass as an obese, cis man? Because, I am going to be seen by the world very, very differently, and they have to stop their hormone treatments during this time. So trans men going through pregnancy, that's a big struggle, but there's not a lot of info on it and we really need more research. So thank you for listening to this very long presentation. I really want to emphasize that this presentation is meant to encourage people that this information is out there available to you. You don't need the answers. You don't have to have the answers with these women. You just have to have the curiosity to go find the information that's readily available. It is our calling as clinicians, doctors, therapists to directly address what patients are most uncomfortable talking about and give them that space, safe space to do it, to have the courage to lean into the pain and talk about those uncomfortable things. I hope that we can do better together to, because the more families we can help, the more parents we can support, that has a huge impact on future generations in society. I'm going to open it up to questions. I'm going to stop sharing my screen. There were some comments I wanted to highlight that were good. Tricia Sadler notes that as an FYI, because EMDR increases can be very stressful experience on the body, that we want to avoid EMDR if a client's having a high risk pregnancy. I welcome anyone to ask any questions or have any comments, okay? Anyone who wants to have a comment or question.
Hi, it's Trisha.
Hi, Trisha.
Hi. Great presentation. Thank you so much.
Thank you.
I am curious more about the bipolar showing up in postpartum for the first time. I have a client that I think that might be happening.
Yes, that's common.
It is. How she claims a couple things. One, I met her during her pregnancy, so I didn't know her before. She claimed that she was a marijuana user as well as an alcohol user before the pregnancy. She's not now. She has had the baby, and her mood swings are all over the place. She's 4 months in to being a parent. And she's afraid. She does have history in the family of bipolar, and she's feeling very impulsive and just not having any clear thoughts.
Does she have a psychiatrist?
No, she doesn't.
That you can call? Get her one soon.
Okay.
I think she's going to need some lithium.
All right. Well, and I
good
approached the
assessment.
subject.
A good assessment. Yes, definitely.
Okay. I approached the subject. She was kind of iffy, not wanting to do that. But I just printed out some assessments to give her so we could do in session next when I see her next. But I'm definitely thinking that's it, especially after hearing this presentation. So
yes. And by the way, guys, I want to show you some of the websites I talked about where you can find this info. Here we go. National Curriculum in Reproductive Psychiatry with these learning modules. Great resource. This thing is getting in my way. Oh, it's going up. Massachusetts General Hospital Center for Women's Mental Health. Oh, that's Zoom. Okay, so, and if you want my slides, I'll put this in the chat. Okay, here's my wonderful husband made a section on my website where you can click here and get my slides, and you can click there and you can get like a list of the books and the websites that were mentioned in the presentation. I don't know if you guys can see that. I'll put it in the chat. So then everybody can have these slides. Oh, whoops, I'm doing a direct message. Everyone in meeting. There. And feel free to share. Yes. So that's good that you bring that up, Trisha, that, you know, I didn't know how related it was, and the PMDD and bipolar disorder. There's a huge relationship, and, you know, the postpartum time is like the riskiest time for women to have their first psychotic break and their first manic episode and first a lot of things. Other good questions or thoughts or any?
Just to say thank you, and I appreciate the resources. I am actually now partnering with a crisis pregnancy center.
Oh, really?
So this will really help a lot.
Yeah, share it with them, and I'm happy to come talk to them too. Thoughts on how we can do this better in terms of like you know, anything we can do as psychiatrists to get information out there to OBGYNs, primary care, therapists, I'm open to suggestions that you guys have too. If anyone has any suggestions or thoughts. Oh, apparently Erica Miley has a question about cannabis in the chat. I'm gonna find it. A lot of she's seeing a lot of PMDD and ADHD. Yeah, I believe that. Oh, any patterns you were seeing on cannabis and PMDD? I don't know. There's so little research on cannabis and it's so much on the rise. It's kind of scary. We certainly don't have any evidence of it being helpful with PMDD, and we have a lot of evidence of being harmful. I think it's got some great medical uses for like glaucoma and for cancer patients. We just don't have any good anything where it's beneficial in psychiatry yet, unfortunately. Any other questions, guys? I'll wait a little bit longer before we end. Any other questions? All right. All right. Have a good evening. Thanks so much, guys. Bye.